subject of revolutionary treatments for brain health, which, by the way, is a very exciting topic for me, having a brain tumor and having gone through brain surgery and my mom and all of that. So this is a very important subject for me. We're going to turn to proton therapy. It's a very targeted type of radiation used in complex brain tumors and cancers. Our next guest is the medical director at UC San Diego Health's Proton Center. Please welcome Dr. James Urbanic.
Well, thanks for having me today. It's a pleasure to be here. I'm up from San Diego, so I'm kind of your local person, I guess, today. So it's nice to be here. So I'm Jim Urbanic. I'm a professor of radiation medicine at UC San Diego. The Proton Center is actually a separate organization, but I run, essentially manage the University of California's proton therapy program. So we serve as a resource for basically the state of California. And I'll try and give you a sense as to what we do, why we do it, why we exist, how I think about it. It's going to be a sort of a major change of pace from what you just heard, where he was talking about sort of treating underlying neurologic diseases, where I'm actually, I'm talking about treating cancer, and my job is to injure things, his job is to fix things, and we'll try and compare and contrast that a little bit. So it's always important to understand people's biases when they're talking to you. So I make my living as a doctor for the University of California, so I am always pro-team. That's who I work for, and I partially make my money doing proton therapy, so you have to understand that as well. My main research interests are in brain tumors. Lung cancer has been a passion of mine for 20 years at this point. I'm one of the national co-chairs of one of the major cooperative groups for lung cancer research in the United States. So that's how I spend a lot of my academic time. When you're thinking about choosing your oncologist, you have lots of choices. I think of it as an incredibly personal decision, but what I always try and be careful to tell people is it's not all based on personality. It's certainly partially based on personality and creating those personal relationships with patients, but it's also based on trying to find folks who have the teams of people in place to try and help you with your problem, right? So I'm a resource for a lot of different medical centers in the state, and I get some of the most unusual cancers that come across my practice and my desk. And so what we're trying to do is figure out how to partner with other healthcare providers in the state, how to get patients well, and how to get them back home. In terms of how do you know if your oncologist is any good, you really don't. So you kind of have to feel it out and realize that if you have a big-time problem, you probably need to see big-time people and big-time locations is probably the first place to start. So just to give you a little overview, and some of this seems fairly obvious, but how do we treat cancers, right? It's a holistic approach, in my opinion, these days. So surgery, right? Surgery is a wonderful option for treating a lot of cancers. If you can remove it, right, you can get rid of a lot of it or all of it right away. And that goes in the brain for both what we call malignant brain tumors or benign brain tumors. If we can take it out, that is the single most efficient way to try and get rid of a cancer. Chemotherapy always comes to mind, right? So medications, drug delivery, to trigger cellular injury with medications. It has an important role in cancer care, but by and large, in and of itself, unless it's a very specific circumstances, it does not cure cancer on its own. And then what I do is radiation treatment. And so what I try and tell people is I'm not a proton doctor, I'm a radiation doctor, and my job is to try and find the right tool in my toolbox for the job at hand. So for some jobs I need a certain tool, and other jobs I need a different tool. Proton therapy doesn't replace all the other tools in my tool chest, which we'll look at in a little bit. And then, it's important to understand that healing the body is also an important part of cancer care. Proper nutrition, immunotherapy is really a way now to turn on your body's own defenses to treating tumors. And then, of course, exercise is another way to try and get your immune system working properly, also tying into spiritual and psychological issues. So I think of proton treatment as a physics and engineering solution for radiation therapy. So I'm an engineer by background. I went to sea on oil tankers for about 7 years as a marine engineer, and then saved my pennies and went back to medical school. And so I think of things in sort of large machinery kind of methods. And when you see what the proton machine looks like, you'll understand why that all fits. But I also realize that we can't just engineer our way out of problem with technology, and I'll try and show you some of the limits of what we're doing and why we need other solutions eventually. And Scotty was right on Star Trek. You can't change the laws of physics no matter how much you try. So we're talking about brain tumors. So why is proton treatment important for brain tumors? We're trying to reduce the risk of injury. So my job is to aim at something with radiation and injure it. With cancer is to kill it, right? So we can cause effects on all the normal parts of the human that are right there. So thinking and memory problems, hormonal changes. For younger people, cancer is caused by radiation treatment is very real. Growth problems in children, visual problems, hearing loss, all of those things. And when you start talking about children and cancer, somebody says asks me, why do I use proton therapy? Even though I'm an adult oncologist, the reason I actually work at the Proton Therapy Center and the reason I support it for the University of California is because our mission at the core is to treat children with cancer. Proton therapy is the preferred method, and we'll look at why that is in a couple of examples, but that's our core business. So for pediatric cancers, in San Diego, nearly all children are treated with proton therapy that need radiation treatment. So that story in California is not universal, and it's a problem. And there are certain diagnoses that we really should be sending all the kids with cancer to proton therapy for, and they don't get it. And that's an access issue, right? We're in San Diego, it's a big state, but we represent about 10% of the U.S. population, and we're the only proton center that treats kids. So it's an issue. For adults in the brain, we can talk about other parts of the body as well. We treat a lot of skull-based tumors, so valuable real estate around people's eye function, brain stem, facial nerves, sinuses, really technically challenging areas to treat. So in adults, we treat a lot of skull-based tumors. And then for, I hate to say your run-of-the-mill malignant brain tumors, because that's, in my world, that's how we think of things, but for normal people, that's not how we think of things. We use proton therapy for patients largely who have a prognosis that's actually really good to try and minimize some of their long-term side effects from treatment. Okay, so who is California Protons? So it's a proton center that's been around for about 10 years. It's one of the largest proton centers in the country. It represents basically the current iteration of technology. And that's important because, technology, just like our cars, changes all the time. So it's 15 minutes away from UC San Diego. We use what's something called intensity modulated proton therapy, and so essentially we're able to shape the beam and the amount of radiation dose we give from any different direction in highly controlled ways. We're able to target on a daily basis using imaging. And we're tightly affiliated with the Children's Hospital in San Diego. So we have hospital licensed space right within the Proton Center. We have a full suite for anesthesia. We put most of our kids to sleep, the little ones anyway, on a daily basis. And then so Rady Children's in San Diego is now, I think, pretty much going to be just part of, they're going to be joining Children's Hospital of Orange County, Chalk, and Irvine. And then we represent a referral source for the other UCs. UCLA, I see lots of patients from there. UC Irvine, of course, which is just up the road, and then across the state of California as well. So we're trying hard to solve the radiation problem. And I say we're trying because we haven't solved it. So this is the problem that has been going on in my career, and this isn't a brain tumor, but this is, I think, a nice way to try and illustrate it. So this is a patient of mine who had an esophagus cancer who I would have treated 15 years ago or so. And so what you're looking at here on the right-hand side of the screen is a slice of bread view of the body. On the left is a side view of the body. And so in the middle there is the heart. The area that's in red is where the esophagus is. And so we're giving a high dose of radiation to the esophagus. This is in preparation for surgery. and then trying to minimize radiation to everything else. But you can see from the other colors there's radiation to large other components of the chest, and a lot of the heart is getting treated with radiation. This is how we did radiation for years, if not decades, essentially around the world. And it's still actually part of the standard of care of what we can do now, which is why one of the tricky things about when we talk about what the standard of care is. This is the next iteration of radiation treatment. So the quick version here is you can see the dose is packed in more tightly around that target, a little less dose to the heart, but we're smearing the radiation out over a large part of the chest. Major issue for the patient, but this was an improvement. This is called IMRT, or volumetric modulated arc therapy, to be technically correct. And then this is what we do with proton treatment, right? So the issue here is the dose to the esophagus for this patient is the same, right? So the goal that we're trying to treat to make this job easier for the surgeon is still the same. But you can see here there's a lot less radiation to the rest of the chest and a lot less radiation to the heart. So we're doing a large randomized clinical trial through our major NCI-sponsored cooperative groups to try and prove that this is better, and not just showing you, pictures on a computer screen. But that's basically in every single scenario what we're trying to accomplish. Why are there so few proton centers? Well, this is one reason. So it's now an industrial scale solution to treating a cancer. So the center in San Diego cost $220 million to build. It was built through private equity, which is, I guess, a dirty word nowadays. I'm not sure. And it's still owned by large banks, basically. And it requires on-site engineers and a whole team of people. So what I tell people is the Proton Center is essentially like, multiple jetliners all sitting together in terms of size and scale, whereas a regular X-ray machine that we use for radiation treatments is like a dump truck, right? So it's a whole different scale of treatment that we use. What we do in that cyclotron is we take hydrogen gas, we turn it into a plasma, we remove the electron, we accelerate the protons up to 2/3 the speed of light, and then we shoot them down the length of the building, right? And that's what the beam line is. And to do that, we have magnets that basically can help steer the proton beam, and some of those magnets are cooled for the scientists in the room to about 7 degrees Kelvin. So the supercooled, superconducting systems in order to be able to steer proton therapy where it needs to go. Inside the treatment room itself, this gives you a sense of the scale of it. That's Rich, one of our physicists, standing next to the gantry. That gantry is 3 stories tall behind the scenes, and it weighs as much as a 737, and it rotates around the patient with about 1 millimeter of precision to do that. And that couch is essentially an adaptive robotic couch from the automotive industry, which again has about 1 millimeter precision in terms of patient positioning. So major scale engineering to do this. Essentially the control room looks a little bit like the deck of, the Enterprise on Star Trek, and how we make all this happen. So what you're seeing here is the machine rotates around the patient. We can actually take an image on a daily basis to try and align our targeting. So a lot of the older proton centers that you may hear about aren't able to do this. And so when you're not able to align based on imaging in my field, you treat to a bigger area, which in some ways actually kind of defeats the whole purpose of trying to be more precise in our treatments. Okay. So this is what it looks like on the business end. So it's a tiny little pencil beam of radiation that goes in, and our job is to stop it at a certain distance based on the density of the patient and how far we want to throw the beam. And so we have to be able to calculate that and control for that and basically create very complex dose clouds. This is what the machine's actually doing with the scanning beam. So this is a thoracic tumor, and the beam scans back and forth across the patient and very quickly can treat the tumor. For a small tumor like this, we'll use radiosurgical techniques and treat it in about 5 treatments. Many of our treatments can take several weeks of therapy. And as I said, for some of our pediatric patients, we actually have to put them to sleep every single day to basically hold them still. So what does this look like in brain tumors, and why is this important? So this person had what's called a low-grade glioma. So their prognosis is they could survive, 15, 20 years after proper treatment for this brain tumor, without getting into the list and litany of factors that go into that. So I don't want to cause them problems from the radiation if I can avoid it. So the proton therapy is on the left, and the simple idea here, as you can see compared to the picture on the right, is we're just treating less of the brain that we're not aiming at. So again, we're doing major randomized trials in the United States to try and prove this is actually going to be better. It's already been accepted in childhood cancers. For kids who come in with cancer, we don't do IMRT for this problem anymore at UC San Diego. We only do proton treatment. But the differences can be subtle, and it's not a tool for everyone. So this patient was actually a gentleman that I knew from town who had a high-grade glioma. He had a glioblastoma, so a devastating, rapidly growing brain tumor. Needs treatment very quickly. Some of what we do actually takes more time to do. And we're not, frankly, worried, unfortunately, about some of the longer-term side effects for this patient. So efficiency, speed, simplicity actually matters. And you can see the slight differences between the left screen and the right screen between proton, actually the left screen and the right screen. IMRT is on the left in this picture and protons is on the right. Really don't justify the use of high technology for this person. So I try and be appropriate in terms of how we decide on who gets and needs what treatment. But this is why in children it's a slam dunk, right? This is why the conversation in California should stop as to who gets proton therapy for children and who gets regular radiation. So this is what's called craniospinal irradiation. There's a whole list of pediatric brain tumors that we treat. The most commonly, medulloblastoma would be the one most people think about. Curable brain tumors. These kids can go on to live relatively normal life expectancy. So on the left-hand side, we're looking at IMRT-type radiation treatments, which we expose a large part of that child's thorax, abdominal cavity, heart to radiation treatments. And then sliding through to the right, in the middle is an earlier iteration of proton treatment where you can see we're able to treat just the spinal column itself. And nowadays, we're only able to treat half the spinal column. And so why treating half the spinal column matters is because if this is a 7-year-old and they're still growing and we don't treat the front half of their bones, they can still grow to a normal height. And so we remove some of the physical deformities that can happen because of cancer care. I tell you that I know that this is not necessarily the routine in all parts of California for kids to get this treatment. Okay. Skull-based radiation. So it's a very useful, very handy tool. So this is an adult patient showing all the same issues, the same pictures for the patient. So the left-hand side of the screen, we're looking at a CT scan with the dose on it, and then below that's a PET scan. And on the right-hand side is a side view with the dose on it, and the bottom is an MRI scan. And so this person had surgery for a meningioma. The meningioma came back, which they can. They don't always, and so surgery is curative for a lot of these. This person, it came back. We were able to target it based on advanced imaging, particularly with that PET scan, kind of really shows where it is. And then proton therapy, what it allows me to do, it doesn't allow me to miss the optic nerve and the retina on the side where the tumor is, although we spared the retina to what we consider a safe dose. But it allowed me to better minimize the dose to the optic nerve on the opposite side, right? So if I'm taking a risk with a patient, I'm trying to explain to them what problems I can cause and what I can try and do to mitigate some of those problems. And so for this person, we're trying to minimize their risk of long-term visual function issues from the radiation, and I'm trying as hard as I can to make that a non-issue in the opposite eye and still cure the tumor. Okay. This is an example of another problem that comes to see me from time to time. So this was a guy who's fully functioning, working as an adult, and he was treated as a child for a brain tumor. And so for the physicians in the room, you can probably get a sense from his cerebellum that it's a little bit smaller than normal on this T2 weighted MRI. So he had prior radiation to the back of his brain for treatment of a childhood cancer. And then he got a cancer. He got a rare tumor of the sweat glands inside his ear. Most of us never knew we had sweat glands inside our ear, but we do, because that's what the cancer was. Recurred. He got surgery at UC Irvine, came to see me, and we had to put together a way to try and treat basically his ear canal without trying to hurt his brainstem. And so we did that for him about 8 years ago now, and he's doing a great, healthy life and has, essentially, as I can tell, no issues from treatment at this point. So, thanks. So another issue that comes up, this is again a skull-based meningioma, so this person's tumor came back prior radiation treatment, and so now not only do we have to deal with the side of the head where they had prior radiation, I'm trying to minimize the nerve to the eye, so we're asked to do this kind of treatment where for prior treatment they come to see us so we can try and help them with it. This person, still fairly soon out from follow-up, so hard to declare victory just yet. We also get patients from all over the world that come to see us. So, and this is sometimes the problems that we see from other places in the world is where they don't have the same level of technology, and so we're trying to piece together sort of handwritten notation and handwritten calculations and try and then patch together what they had done so we can come up with something to do for them. So this person had a brain tumor treated previously, and we're patching together the treatment they need now. And I don't think I can answer their question on the outside of the wall there, but I'll try. All right. And that's all I had for you. So on time and under budget.
First of all, who is proton therapy best for?
Best for?
Is it better than the traditional radiation that they offer as standard of care for brain tumors?
It's best for patients with a good prognosis, so we have an opportunity to minimize their long-term risks, and in parts of the brain that have a lot of high-value real estate, so something near the brainstem, something near the facial nerves, the skull-base region.
Like mine is on the trigeminal nerve.
Correct.
So that would be better for someone like me.
I would think so.
Okay.
If you needed it. I hope you don't need it.
I sure hope so. Hope not. So it's better for those areas.
Yes.
And better than going to the traditional radiation.
Yeah, simply not because the dose to the target is any different. Like if we're treating something to the dose of, say, 50 gray is the number that we use. It's going to be 50 gray with proton treatment or 50 gray with regular radiation. It's what can we miss and what can we try and not cause a problem to down the road.
Got it. So the traditional radiation would be maybe a little more dangerous in those high-risk areas than the proton therapy.
It might have some bigger chance of causing a hearing loss, an eye injury, a brainstem injury than we might. There are other techniques we use in the brain, base of skull, brainstem area, like radiosurgery. So you'll hear about gamma knife radiosurgery, cyberknife radiosurgery. I actually do those treatments as well. And so the other piece that goes into it is a size one. So proton therapy for super small areas is not quite as nice as some of the radiosurgical techniques. So there's a sweet spot. So I kind of meant to mention when you're trying to talk to your radiation oncologist, you need to really be talking to somebody to make sure they have not necessarily access themselves to the full range of options, but they have knowledge of the full range of options, or they know who to ask about how to get those options.
Got it. And what are the side effects that you have seen with proton therapy? And are they different than traditional radiation?
So they're largely the same in the sense of how somebody goes through treatment. So if I'm treating someone's brain with radiation, I'm causing an injury to the brain, I'm causing inflammation in the brain, and the body's normal response to that is tiredness, right? Mm-hmm. That's the single most common thing. So people get very, very tired from radiation. We do cause hair loss, sometimes permanent hair loss, because the angles that we use with protons are a little less. It's usually a smaller area of hair loss. The things that I worry about, the ones that keep me up at night, brainstem injury, nerve injury, those sorts of things, I'll oftentimes consent patients to the same risks because they still exist, but I'm actually trying to cause a risk reduction. It's all about risk reduction.
Mm-hmm. So I guess with traditional radiation, they always say that those are the only side effects, but I've seen worse side effects that has scared me away from radiation in general. Like, for example, my mom had glioblastoma, and she was just not the same after. She was like a kindergartner. But everybody says that radiation is generally safe and it's just a little inflammation and it goes away. I didn't see that happen. And is it different for glioblastoma and meningiomas?
It's different, and it's largely different based on the size of what we're trying to treat. So a glioblastoma has spider webs. It's a very diffuse, infiltrative tumor. We're treating generally large areas of the brain. So in addition to tiredness, absolutely we can see cognitive changes, thinking changes, personality changes with any type of radiation. In children, for high-grade gliomas, we use proton therapy because we're going to do, even if there's a minimal risk reduction in a child, we're going to do it. What I've seen in my practice in adults for aggressive, large area tumors in the brain, I don't see any advantage to proton treatment, so I don't encourage the use of the technology for that. For meningiomas, there are different meningiomas. I mean, some patients come to see me and they have fairly diffuse meningiomas, and proton therapy for that scenario can actually be very helpful, where we're treating a larger rind of the brain. For small meningiomas, it's really a picky-choosy kind of thing on how we do it.
What about dementia related to radiation therapy?
Yeah, I mean, so those cognitive changes in some cases can look very much like Alzheimer's disease or dementia. I've seen patients in 20 years in my career that we've treated for low-grade gliomas who, have that long-term prognosis, and we'll see them back in clinic, and they have long-term, cognitive decline. It's real. Again, proton therapy doesn't fix it, but it can try and ratchet the problem down a bit.
And is it to shrink them or to stop them from growing?
So for a lot of things, it's to do both. For a meningioma, for example, it tends to have a substance to it. It's a lining surface of the brain. The meninges functions in part to keep the brain under pressure with the spinal fluid as a shock absorber system, and to as a way to transmit different signals throughout the CSF system. So it's gonna be like that piece of paper. It's not just gonna melt away, but the cells within it we're trying to kill. So our first job is to shrink it, and then a meningioma in particular, because it has that sort of honeycomb effect to it, may shrink some over time, and it can be a slow thing. For a infiltrated brain tumor, we are absolutely trying to kill those cells and make them shrink. And one of the challenges when we do long-term imaging is there can be chronic changes in the brain from the treatment, from the injury that I caused. It's very hard to tease out what's tumor and what's my effect.
And so if you have a child with cancer, I think we've basically said that this is helpful in pediatric cancer. What should parents ask for? And is it only in certain cases, or is it always for kids proton therapy is the first choice?
So for children with cancer, we treat not only pediatric brain tumors, but we treat almost all of the sarcoma type cancers with proton therapy for folks that are in kind of our network. And so I would say that if a parent has a child with cancer somewhere, that's not near a proton center, and so nowadays Salt Lake City, Phoenix, Seattle, Houston, Texas, Dallas, all those major cities have proton therapy. But if you're in Denver, if you're in Los Angeles, you may not have the same access, and you have to ask the hard questions of the oncologist, and you have to sometimes just get a second opinion from any of those places to make sure you're understanding what's reasonable. And we do second opinions by telemedicine all the time. So.
What's next? What are you researching next?
So we participate in a number of things. So on the pediatric side, we participate in as many of the Children's Oncology Group clinical trials as possible. So we have essentially through Rady's Children's Hospital, we have the full spectrum of trials available. For myself, I actually have a partner who I work with where we're doing long-term data collection on the neurocognitive impacts of radiation treatment and trying to see how we can correlate missing certain parts of the brain with radiation and then how patients do, so we can come up with ways to try and better steer the radiation based on that.
Because can you make the target area smaller? Like, that's what I always ask the radiologist. I'm like, can't you just hit the middle and hope it all just dies after? But you can't.
No, you can't.
Unfortunately.
Yeah, you have to. So, the goal of imaging is to try and give you as precise a picture as possible. So on that one example, the meningioma I showed you all with the PET scan on it, when we originally looked at that in what we call our tumor board, which is where we all sit down together to look at it, the amount of disease that was in the bone was kind of unrecognized for that patient. So that better imaging allowed us to do a better job of targeting their complete tumor. And if I had just done my treatment based on the MRI, I would have missed part of it. So, so sometimes the imaging makes our things bigger. On the other time, sometimes imaging can then go the other direction, where the imaging, more advanced imaging may help us find a smaller target. So.
Got it. And then you were saying you were working on helping with the cognitive deficits. What have you seen that's worked so far?
So the simplest thing is the less of the person's brain that I can treat, the better.
Yeah.
Right? So it's not a fancy
Which
answer.
is why I haven't given my brain to anyone yet. I'm like, no, not until it's absolutely necessary. But that's the point,
That
right?
is the point, yeah. Not until it's absolutely necessary. And as small a target as we can come up with a radiation technique, of which there are several where we're trying to minimize the dose exposure to other things. That's number one. We've tried drugs. We've tried Ritalin, we've tried Provigil, we've tried all of the Alzheimer's drugs for radiation injury.
The Adderall does work, because so one of the parts of this that's really hard as a caretaker is, you guys only have so much time, and you say things all day long. You don't know who you said it to, who you didn't say it to. So I got to a place where my mom, I was like, what do I do? This is so challenging. And her brain just wasn't working well. And I had this moment where just, common sense just pops up. I'm like, I wonder if we gave her Adderall. I just interviewed Maria Shriver. She had done a documentary on Adderall, and I jokingly was like, oh, why didn't I do this? I would have been even more successful in life. Kidding. But it gave me the idea for my mom to give her Adderall to help get her focus back.
Right.
And it did assist. It did help.
Right. I think things like that, I was going to say, can be helpful, but they're not fixes.
Yeah.
Right. And so they can take the edge off. And they also there are simple things like that we can try on someone and it helps and let's keep going, but we try on somebody else and it doesn't, so we stop. Which is why for some of these things on a population basis to generate the data is tricky, because when we generate data, we tend to look at, averages of how things work rather than specifics in any given scenario.
Yeah, and health is so individual, so each person is going to have a different response and reaction.
Yeah, potentially, yeah.
Yeah. Well, I am very grateful for this conversation, Dr.
Sure.
Urbanic. Thank you so much. Obviously, we mentioned he's at UC San Diego's Health Proton Center, if you guys want to look that up and get any more information.